In the first place, I would like to thank Jose Miguel for giving me the opportunity to present this webinar to you today. And the title for the lecture today is about rotations of the maxilla and the occlusal plane, the key to successful orthopedics. It's about orthopedics in class 3 growing patients between a mini plate on the infrazygomatic crest and a second one between the lateral incisor and the canine in the mandible. The patient is wearing intermaxillary elastics 24 hours a day. The final design we are working on since long time, together with my wife Hilde Timmerman, who is an orthodontist too, is a 3-holes mini plate in the upper jaw and a 2-holes mini plate in the lower jaw. At the end of the mini plate is a tube with a size of 1825 and an elastic hook that can be used to fix the intermaxillary traction. Intraorally it looks like this. The upper and the lower round bar is perforating attached gingiva so that we get a good healthy adaptations of the soft tissues around the mini plate. In cases where we have a crossbite in the incisor region, we need to combine the elastic traction during the first month with a bite plate. We prefer removable bite plates, as you see on the picture here. The patient is wearing them day and night. He has to eat with them, and it's only interrupted after the crossbite in the anterior region is completely corrected. It looks like this, with an occlusal surface which is covered by acrylic, and a typical case, class 3 growing pattern with a pronounced chin and a short upper lip. These are the early bulky designs of the mini plates, but here the patient is 11 and we will see her pictures now at the age of 21. She had a crossbite at the beginning of treatment, so we needed to use a bite plate the first months until the crossbite in the incisor region was corrected and the traction is held on for 1 year. The initial occlusion, the dental casts on the top, and after 1 year of intermaxillary traction. As you see, the class 1 molar occlusion was transformed into a huge class 2 malocclusion, so in the next step of treatment we will distalize the upper molars and premolars by reusing the upper anchorage so that we can avoid to remove bicuspids, what we should do if we wouldn't have had this skeletal anchorage. So we use a skeletal anchorage to distalize the upper, the second premolars and the molars, and to bring the cuspid at its place without removing premolars. The occlusion at the start of the orthopedic treatment on the top, and after 1 year of intermaxillary traction and 2 years of fixed appliance, the patient is 14 years old now when we took the intraoral pictures on the bottom. Now the patient is 21 years old. The occlusion still looks quite nice. We got a small reopening of space in the premolar region on the bottom, but a quite nice occlusion at the end of growth. The profile changes at 11 on the left side and after 1 year of intermaxillary traction, with most of the changes at the level of the upper lip. 3/4 pictures, 1 year of intermaxillary traction from bone to bone, from upper jaw to lower jaw. And here are her pictures at the age of 21, so quite good stability of the class 3 profile changes. In the early years, we only had 2D cephalometrics, and we found out that in all the cases we treated from the beginning, we found out some extra forward displacement of the midface and a restraint of the forward projection of the mandible, with appraisal changes, in this case of 1 centimeter. Later on, we had the progress that we could take CBCTs with an acceptable dose of radiation, and thanks to the fantastic work from Lucia Sevidanes at the University of North Carolina, she made it possible for us to do a registration of 2 CBCTs, the first one on the left side that we took at the beginning of the orthopedic treatment, and the second one after 1 year of intermaxillary traction. The anterior cranial base is very stable and completely automated. Both images were registered on this anterior cranial base. And then by a special software, the distance was measured between the bone surface of the different facial bones before and after orthopedic treatment, and depending on the distance of the displacement, all the different points were colored red for movements towards us and blue for movements back to us. Initially, these pictures gave us an idea of where the changes were obtained, and here, as you can see, it was the whole midface, both zygomas and the maxilla that was moved forward in this patient. And the same patient we can look at in a different way. Instead of using color maps as we see on the left side, we can use semi-transparency tools like we see on the right side, where the color was of the skull was red for the beginning situation and transparent grid after protraction. Now, the problem was that in the early years we were so amazed and startled by these beautiful images from Lucia that we thought that due to this intermaxillary traction we got a pure translation of the midface. And this is because you see that there is quite some play between 3.5 millimeter and 5 millimeter forward protraction. It all gives some kind of red color, but it doesn't mean that the whole midface moved forward in the same way and the same distance in the anterior nasal spine, for instance, and in the infraorbital rim. It was at least not what we expected, but because already end of the 1980s we did experiments on dogs and found out that if you apply a protraction on the maxilla of a dog, since the center of resistance is always can be estimated to be somewhere above, we found out a huge amount of anterior rotation of the maxilla. And also Dr. Teuscher in 1986 already suggested that when you apply orthopedic forces by headgear or face mask to the upper dentition, because the center of resistance of the dentition and of the maxilla are definitely situated above the place where we apply the forces, that we may expect rotations from the maxilla and rotations of the dentition. And to illustrate this and how important this is, I would like to present this class 2 malocclusion. It's a lady, 30 years old, that in 2003 went for the first time to an orthodontist, complaining about the crowding that seemed to increase year after year, as well in the upper as in the lower incisor region. The orthodontist said that the malocclusion was just the result of a bad growth pattern, and in fact that her mandible was positioned too much backwards compared to the upper one, and this is reflected in the occlusion in a class 2 malocclusion with sagittal overbite and as a consequent increasing crowding. So he convinced the patients to go for an orthodontic surgical treatment so that after decompensation of upper and lower arch, she got the surgery by advancing the mandible. And here we have her profile in the beginning of treatment on the left side and after the orthodontic surgical treatment on the right side. However, the orthodontist had very difficult to get a stable occlusion, and there was still some tendency of open bite at the end of the treatment after removing the fixed braces. We can better see it in the close-up pictures. On the left side, the overjet at beginning of treatment and 2 years later after the orthodontic surgical treatment. 5 years later, the patient comes for the first time in our office. These are her facial pictures, relapse of the convex class 2 profile, incompetence of upper and lower lip and closure of the mouth. Smiling pictures, she still has the fixed retainers behind upper and lower incisors. On the left side, the facial profile before treatment, 2005, after surgery, and 5 years later relapse. The occlusion was a complete open bite from first molar to first molar on the other side, and only contact at the level of the second molars. Huge sagittal overbite 30 mm and an open bite of nearly 7 mm. We see it better on the CBCTs, only an occlusion and contact in the second molar region. Not so long before, Michael Gunson and Bill Arnett, two famous maxillofacial surgeons in California, published a paper on the condylar growth resorption caused by bad and wrong oral contraceptive medication and a lack on hormone level of estradiol. We checked this in our patient and found out that estradiol was not detectable when she did the test with the endocrinologist. So after changing the contraceptive medication and after restoration of the hormone level, we started orthodontic treatment. Intrusion of only the second molars by a lever arm from the lower bone anchor that passively was here. We fixed it to the molar and applied a very light intrusive force on the molar on the left and the right side. The same on the upper side, just some extension and a power thread to the labial hook on the upper molar band. Now if you do that, of course you get rolling, buccal rolling of the teeth. To avoid that, we fixed a very rigid TPA from the left to the right second upper molar and a very rigid lingual arch in the lower jaw. Very quickly, after intrusion of the second molars and then after the first molars, we got complete open bites. So finally we intruded after the molars, the second premolar and the first premolar, and very quickly we saw a very important change in the open bite and the sagittal overbite by auto-rotation of the mandible. On the top, the beginning of intrusion, in the middle after 4 months, and on the bottom the situation after 1 year. No intermaxillary elastics have ever been worn. The condition for the patient to take off the braces is that we fixed all the teeth. In fact, the retainers that you see is a design from the patient. She was so traumatized by the relapse of her previous treatment that she was so afraid that the history would repeat itself, and this was the only condition we could convince her one day to remove the fixed appliance. Facial changes on the left side, beginning of molar and premolar intrusion, and 5 years later now, today, how she looks like. So there was some slight auto-rotation of the mandible. Occlusion on the upper left side, beginning of the first treatment, and on the right side, after the first treatment, beginning of intrusion, and 5, 6, 7 years later now already we have this occlusion, and we can just hope that this will stay stable. Now, why do I show you this class 2 case? Because I was so much impressed by the fact that only very small intrusion of the posterior teeth could result in such huge changes of the occlusion and autorotation of the mandible. We know from the work from Björk and Schiller that the upper molar, all during lifetime, and especially between the growth period from the age of 4 until the age of 20, moves down about 30 millimeters. Half of that is due to growth changes, suture growth, and downward movement of the upper jaw due to growth effects in the craniofacial sutures, and about 5 millimeters of the downward movement by growth is obtained due to remodeling of the palatal plane by resorption at the nasal site and apposition at the intraoral site, and half of the downward movement of the molars is due to extrusion and dentoalveolar changes. So, if the upper molar moves 30 millimeters downwards, 1 or 2 or 3 millimeters more or less downward movement of the molars may have tremendous effect on the vertical changes in the face. To illustrate that, we have the research from Hugo from Turkey, published in 2015, where she shows her approach to change the class 3 growth in young, early mixed and late mixed dentition patients. She makes a corticotomy on both sides of the maxilla, and she does a classical class 3 face mask treatment in the beginning to a face mask, and after some time also to skeletal anchorage in the mandible. And what you can expect is, of course, that if you do that and you make an incision here, that the center of resistance should be somewhere there, so the traction results in huge rotations of the upper jaw. Rotations in the mean of about 8 degrees anteriorly, and this of course leads to a downward movement of the upper molars and the creation of an open bite. The solution from the authors is to compensate for this anterior rotation of the maxilla by chewing gums 3 times a day during half an hour. But what happens if you use face mask mid-face protraction on an upper splint without doing the corticotomy? Also in these cases we expect that the center of resistance of the upper jaw should be somewhere upwards and above the occlusal plane, so we expect an anterior rotation of the maxilla. In fact, if the center of rotation, the center of resistance of the upper jaw is positioned above the line of force, we get an anterior rotation of the maxilla. That is what we should expect from a biomechanical view if you apply an anteriorly directed force to the upper jaw. This results in extrusion of the upper molars and some forward displacement of point A. That such a rotation occurs, we found it very early, in the early years when we did this research, when we got our first CBCT images. On the left side, a boy 13 years old before protraction, and on the right side, after 1 year of 24 hours a day intermaxillary elastic traction. And if we look at the zygomaticotemporal suture that was completely smooth and parallel at the beginning of treatment, it got opened completely on the lower side of the suture and compressed at the upper side. If we saw these pictures here, this was another sign that confirmed our idea that the midface was not pulled parallel forward, but there was some kind of anterior rotation. We saw it also on the cephalometric data that we got from our treated patient group compared with the control, that the infraorbital rim moved about a millimeter less forward than point A from the maxilla, again showing that most probably this was due to a kind of anterior rotation of the maxilla. So what we get is an anterior rotation of the maxilla and an asymmetrical opening of the suture between the zygoma and the temporal bone. How far can this protraction and anterior rotation go on? How long can it go on? Well, there is some limits, and one of the limiting factors is the occlusion with the lower molars. The upper molar moves down until it hits the occlusal surface of the lower molar. The contact with the lower molar will push and restrain the downward movement of the upper molar and restrain the anterior rotation of the maxilla. This restriction of the forward movement and anterior rotation of the maxilla is further amplified by the bite plates you use, especially first of all because of the thickness of the bite plate. You increase the vertical forces transferred to the upper molar and the posterior part of the upper jaw. So due to that, the spontaneous eruption of the upper molar is restrained, and we can even get some intrusion of the molar. That explains why, despite the fact that we get an anterior rotation of the palatal plane, these authors found no rotation of the occlusal plane because the upper molars were pushed up and we got some over-eruption of the upper incisors. We see it also in the overall tracing in this paper, where you see that the upper molar hardly didn't move downwards, where they definitely did in the control group. And we see an anterior rotation of the maxilla and a slight posterior rotation in the control group. Although these rotations are very small, we know that very small differences in vertical displacement of the upper molars may result in huge changes of rotation of the mandible and AP position between upper and lower jaw. But there is another reason why the bite plates may restrain the orthopedic effect. All patients that get bonded splints on the upper dentition will, by grinding, especially at night, will create indentations in the acrylic, and these indentations will restrict and restrain the AP changes between the upper and the lower dentition and between the upper and the lower jaw. That's why it's so important that when you use bite plates, it's better to use removable ones, so that each month you can remove the bite razor and check all the indentations of the cuspids of the lower premolars and molars. And if you don't do that, this will definitely restrain the orthopedic midface growth stimulation that you expect to get from your face mask or other device. So every month it's so important to grind these occlusal surfaces so that you get smooth surfaces, so that you don't get interlocking of the lower cuspids. And sometimes this may lead to perforations of the plate. So in these cases then you have to start filling up the holes instead of continuing drilling and milling the acrylic of these removable plates. Another big question is, when should you best start an orthopedic treatment to correct a class 3 growing pattern? Is it in the early or in the late mixed dentition? Based on papers like this one from 1998 that have been cited so numerous times in the years thereafter, they found out that no significant maxillary modifications were recorded in the late treatment group. In fact, what they did, Tiziano Baccetti, Lorenzo Franchi, and Jim McNamara, they compared two groups of patients, both treated by face mask and rapid maxillary expansion. One at the age of 7 and the other at the age of 8.8 years. And they found out a nice stimulation of the forward displacement of the midface in the 7-year group, but nearly 2 years later they found no significant changes anymore using the face mask. And this is amazing because both groups of patients have been treated by face mask but preceded by a rapid maxillary expansion that is done to mobilize and disarticulate the sutures. This has become the standard for face mask protraction, doing a rapid maxillary expansion first to disarticulate the sutures to improve the outcome of the midface protraction. However, already in 2005, Dr. Vaughan from the research group of Patrick Turley in Seattle found out that if you treat two groups of patients by face mask, the first one preceded by rapid maxillary expansion and the other one without rapid maxillary expansion, and you do this in a prospective randomized clinical setup, they didn't find any difference between the outcome of the midface protraction between the group that had expansion and the group that had no expansion. So maybe a single rapid maxillary expansion is not sufficient. That's why Dr. Eric Liu proposed his protocol of the alternate rapid maxillary expansion and constriction. In fact, he expands the upper jaw by a rapid maxillary expansion during 7 days with an activation of 1 mm a day. But after the first week, he closes the screws completely the next week, and he follows this protocol for 9 weeks long. So this alternating expansion and compression cycles should better disarticulate the suture and should result in better protraction of the midface. However, there is till now very little evidence that proves this hypothesis. And at least in this serious paper published 2 years ago, they found out that if you compare a patient treated by face mask with alternate rapid maxillary expansion with another one treated with one single rapid maxillary expansion, that there were no clinically relevant difference between both groups. So it seems that it is absolutely not needed, and it makes no sense to do rapid maxillary expansion before protraction. But in some cases we still do it. In cases where we have mild crossbites, like you see here, a unilateral crossbite only on the patient's right side, these mild crossbites will correct themselves during the orthopedic treatment, as we see here. So the crossbite on the right side was spontaneously corrected by the AP changes following the intermaxillary traction. But sometimes the discrepancy between the width of the upper jaw and the lower jaw may be that important that even if you get huge AP anteroposterior changes, that this will not be sufficient to correct the unilateral or bilateral crossbites. So cases like this, where there is an important discrepancy in the width between upper and lower jaw, yes, in these cases we start by a rapid maxillary expansion first. Immediately after, we continue the intermaxillary traction, so the pictures on the top are immediately after the expansion, and here 1 year later. So the beginning of treatment with a unilateral crossbite, yes, in these cases we do expansion first, and then we do the 1 year of intermaxillary traction. Before and after on the right side, and here 5 years out of treatment. So if bite plates have a number of disadvantages, is it better than to use banded expanders? One of the most famous papers on face mask therapy published is from Patrick Turley in 1999 using these banded expanders. What did they find out? Well, exactly as has been found out by Lorenzo Franchi, Tiziano Baccetti and Jim McNamara, they found an anterior rotation of the upper jaw. But since they didn't use bite plates, they got more extrusion of the upper molars. Now the fantastic thing about this paper from MacDonald and co-workers is that for the different cephalometric points, they measured the vertical mean displacement, and they found about 1.4 mm downward movement of the posterior nasal spine and no movement of the anterior nasal spine, again showing the anterior rotation of the upper jaw. Upper molar cusp moved down about 1.2 millimeters. However, what they found is that the upper incisors extruded 2.7 millimeters, highly significant. And this is so special because the anterior nasal spine didn't move downwards. So we get double as much spontaneous over-eruption of the upper incisors compared with the amount of downward movement of the posterior nasal spine. So what we get in fact is anterior rotation of the maxilla, downward movement of the molar. Due to that you get the creation of an open bite in the front, which is spontaneously compensated by an over-eruption of the upper incisors. This explains why they found an anterior rotation of the maxilla, but found a posterior rotation of the upper occlusal plane. The downward movement of the upper molars resulted in a posterior rotation of the mandible. Every millimeter the upper molar comes down, the lower molar is pushed down and will result in a posterior rotation of the mandible and an increase of the vertical dimension. This posterior rotation is further amplified by the chin cup of the face mask. What makes a difference between conventional anchorage with a hyrax with 4 bands and skeletal anchorage? This has been investigated by our colleagues in South Korea, and they came to a strange finding that if you treat a patient with a face mask by using the classical 4 bands banded hyrax to the upper dentition, Or if you do that with the same face mask but fixed to a mini plate on the infrazygomatic crest, they found about double as much forward movement of the midface. This is not what you can get by using hybrid skeletal anchorage, because in these cases the upper molar is fixed by some kind of rigid connection to a screw in the palate, so it is not a good idea to use skeletal anchorage in an indirect way, so the forces are still applied to the upper dentition, which will extrude the upper teeth and definitely increase the posterior rotation of the mandible. What you should use in the upper jaw is skeletal anchorage, and mini plates are the best to be used, because then you can use them afterwards as an anchorage to distalize the upper teeth, since the screws are inserted at a distance from the roots of the upper teeth. Since about 2 years we are using now Y-shaped mini plates, as you can see, as well in the infrazygomatic crest as in the mandible, which gives a couple of advantages, we think, compared with the classical straight line mini plates. Surgery and the way it is done is most important for the success of treatment. So therefore I think it is so important that you give this website to your surgeon with the login, so that they can look at them to see how exactly they should insert this plate. Surgery is easy but is delicate, and the best way to motivate surgeons to look at this is to send them a video on this website bollardcourse.com with the login Bollard Surgery with capitals B and S. They can look at a short video for the upper and the lower surgery. In 2011 we published the paper on the first 25 consecutively treated cases in our office in Brussels. Mean age about 12 years, mean width appraisal -5, treatment about a year, CBCT before and after. In UNC, Tung Wen and Lucia Sevidanes made the registrations on the anterior cranial base, and what we found out from this first series of patients is that some of them got mostly a stimulation of the growth of the midface, and others got mostly a restraining and even posterior movement of the mandible, and some others got combinations of both. So the outcome of the orthopedic effect is highly variable from patient to patient. In our early studies we compared our approach with traction between mini plates on the upper and the lower jaw with the classical group treated by standard face mask protocol preceded by rapid maxillary expansion. 8 years old, 11 to 12 years old. And we found about double as much forward displacement of the midface compared with the conventional standard face mask protocol. Explanation for this huge forward displacement was found in a distraction and an opening of the zygomatico-temporal suture and of the transverse palatine suture. We could visualize this on the CBCT's 3D renderings, but we could see it also on the palatal side with a very nice opening and distraction of the whole transverse palatine suture. Huge forward displacement of the anterior nasal spine and a complete restriction of the forward movement of the mandible. In the 3D images, again based on the superimposition of the CBCTs on the anterior cranial base, we found definitely the biggest impact in the forward movement of the soft tissue lip. As we see also in these CBCT pictures from a patient where you see that the upper lip and the nose tip has been moved forward, whereas the lower lip has not been affected anterior-posteriorly by the treatment by intermaxillary elastics on bone plates. This is the most important changes we ever found out: an 8 mm forward displacement of the midface, complete restriction of the forward displacement of the bony chin. And if we look at the infraorbital rim, we see that also the both zygomas moved forward together with both halves of the maxillas during this traction. In 2015, in Turkey, all our studies have been done over in nearly exactly the same way. They compared a group of patients treated by intermaxillary traction on mini plates on the infrazygomatic crest and the canine region, compared with the face mask group, about the same age group as we did. And they found only half of the changes that we obtained during our initial studies. When we looked more in detail at the protocol of their study, we found out that there still was some difference between what they did and what we did about 10 years before. Is that in their study they used bite plates, and maybe this is another support of our hypothesis that bite plates decrease the anterior rotation of the maxilla, and due to indentations will definitely restrain the forward movement of the upper jaw. So only half of the changes that we found in our studies. However, last year a very important paper was published following a collaboration between the Tanta University in Egypt and the Illinois University in Chicago. And what they did, they compared a group of patients treated by mini plate anchorage as we use on the infrazygomatic crest and in the canine region, and they compared them with a group treated by face mask, but not with conventional anchorage by splints of bonded or banded hyrexes, but with mini plates in the upper jaw. And what they found out is very, very surprising. They found an amount of midface protraction which was very comparable with what we found with our study. However, if they compared these results with the face mask group, treated not at the age of 8 or 9, but at the age of 12, they found about double of the forward displacement of the midface compared with what we normally do with conventional face masks used with bite splints or hyrexes fixed by 4 bands. Is this protocol also working in cleft patients? We know that during closure of the clefts in the early years after birth, you get scar tissues. Scar tissues at the level of the soft palate and scar tissue at the level of closure of the hard palate. Thanks to a fantastic collaboration with the Centrinho clinic from the University of Sao Paulo, we were able to do a prospective study on cleft patients that have been treated with our protocol. And one of the patients we treated there was Guillermo, as we can see on the pictures here, with the typical class 3 profile with a complete dished in midface due to scar tissues created by the surgeon by closure of the lip, hard palate and the soft palate. Here we see him again after 18 months of intermaxillary elastic traction on 4 mini plates. All credits to Daniela Garib and Renato Facco. Daniela, who is responsible for the clinical study, and Renato Facco, who is the surgeon of the craniofacial center. Occlusion at the beginning of the treatment and after 18 months of intermaxillary traction. CBCT superimposed on the anterior cranial base. Just as in the non-cleft patients, a huge protraction and forward movement not only of the maxilla but also of both zygomas. Here we see the complete cleft on the patient's left side. We did this study on a continuous series of patients of 20 treated all in Centrineo Clinic in Bauru, and you see that we got also some variability in the outcome, but in the vast majority we found nice protraction of the midfaces. And as we later analyzed them and all these data are published now, we got a mean forward displacement which is nearly comparable with what we found in the non-cleft patients. So we can conclude that if you protract a midface using skeletal anchorage on the upper jaw and skeletal anchorage on the lower jaw, you may expect about 5 mm forward movement of the midface. This was obtained in our study and was confirmed later by the study from Egypt and from Illinois. What we found out in the rotation of the mandible, which was not the subject of the lecture today, is that we got some slight closure of the mandibular plane angle, whereas when you treat patients by face mask, that you get always an open rotation of the mandible, which is another very important advantage of using skeletal anchorage, not only in the upper jaw but also in the lower jaw. And most important is that if we compare our face mask group from our study with the face mask group from the study published in Illinois, we see that they got double as much forward displacement of the midface because they used skeletal anchorage combined with face mask, and this without rapid maxillary expansion at the age of 12, when it is expected still today that it is too late to protract midfaces by using a face mask. So, what's the catch of the day? In the first place, we are strictly convinced that you should not use bonded acrylic splints to protract midfaces. Because of the thickness of these plates, this will further restrict maxillary rotation and protraction. But more important, indentations may restrict AP changes of the maxilla and the mandible, and these are difficult to grind and to eliminate into the mouth with a bonded acrylic splint, so that's why you should better use removable bite plates the time you need to cross the bite in the incisor region. Early or late mixed dentition, in contrast to what we believe since 30-40 years, it seems not to be relevant. Studies have shown these days that you can get double as much protraction of midfaces at the age of 12 than you get at the age of 8, under condition that you use the correct anchorage. Does it make a difference to do the rapid maxillary expansion or the alternate expansion and constriction protocol? It seems that it does not affect the amount of maxillary protraction. The key factor for successful protraction of the midface is the anchorage. If you use skeletal anchorage in the upper jaw, you get twice as much forward displacement of the midface than what you get if you use conventional anchorage, bite plates or banded Hyrexes. Even with face mask, you get up to nearly 5 mm protraction at the age of 12 without rapid maxillary expansion if you use mini plates in the upper jaw as anchorage. But still you have the disadvantage that using face masks results always in a posterior rotation of the mandible and an increase of the vertical dimension. And this posterior rotation of the mandible is the part that results in most relapse after finishing your orthopedic treatment. And although we have no evidence for this, most probably the compliance for using intermaxillary elastics should be better than compliance for using extraoral devices like face mask. So the final conclusion of this lecture is that in the future we should think less anteroposteriorly and think more vertical. What we mean about this is that in the contrast to what we thought initially, is that we are always getting rotations of the maxilla, and due to these rotations of the maxilla, downward movement of the upper teeth. And this we have been underestimating because we have been blinded by the beautiful 3D images that were registered on the anterior cranial base showing complete red coloring as well of the zygomas as from the maxillas. But now we know that also with bone-anchored maxillary protraction we always get anterior rotation of the maxilla, and this may have a limiting factor on the amount of protraction that we can get also with our protocol. So in the future we should study further this kind of rotation and look more at vertical changes than just at AP changes, as we are used to do when we speak about class 2 or class 3 correction of malocclusions or growth patterns. Thank you so much for your attention, and many greetings from Brussels. Bye bye.